Advisor for Policy, Advocacy and Learning with PATH's Sexual and Reproductive Health team. Next slide. We're excited to welcome speakers from around the world to today's webinar. Through the course of our event today, you will hear from colleagues based in Nigeria, India, Kenya, and the US regarding their experiences advocating for introduction and scale-up of reproductive health products. While our presenters will reflect on successful advocacy tactics, they will also share with you what happens after the documents are signed. What do advocates and influencers need to do to push policy into practice? We look forward to an engaging discussion. If you have questions for our speakers, please type them into the Q&A box, which is located on the bottom of your screen. You can also use the group chat to input questions. Questions will be answered live or through responses in the Q&A function on Zoom, depending on how our time goes. We do have plans for time at the end of the webinar for general Q&A as well. So we hope to address a number of questions live, but we will do our best to answer all questions through the Q&A box. Next slide. For any of our participants unfamiliar with the Injectables Access Collaborative, or the AC, we are a coordination and technical assistance initiative led by PATH in partnership with the Clinton Health Access Initiative, In Supply Health, JPIGO, and JSI. In addition to data-driven technical assistance and coordination, the AC provides resources and tools to ensure women and girls have increased access to DMPA-SC and self-injection as part of an expanded range of contraceptive methods delivered through informed choice programming. We are so pleased to be co-convening today's webinar with the Reproductive Health Supplies Coalition. Over to you, Reina, to describe the caucus. And next slide.
Thank you, Bonnie. As you can all see on the slide, the New and Underused Reproductive Health Technologies Caucus is a working group with the goal of helping improve the availability of choice in reproductive health technologies. We want to contribute to country-level efforts to achieve universal access to reproductive health services and products and facilitate their use. And one of the ways in which we do this is by sharing information on faced common barriers and challenges, from product introduction to scale-up and more. And there's a link to today's subject. And if you want to know more, you can follow the link on the screen, or we can drop some links in the chat later. Thank you, Bonnie. Over to you.
Okay. Next slide, please. So as we move into our presentations, I wanted to take 1 minute to set the scene. This slide reflects work done by PATH's Capital to Clinic initiative to understand the bottlenecks that prevent implementation of health policies, a critical factor in building strong markets for and increasing access to reproductive health products. Today's panelists will speak to many, if not all, of the elements shown on the slide here, but they'll be emphasizing the efforts needed to successfully implement, monitor, and revise policies to advance access to RH products. We'll drop in the chat a link to these Capital Clinic resources if you are interested in learning more about that. Okay, over to you, Reina, again.
Thank you, Bonnie. To continue with the session, I am going to present Beth. Beth is the chair of the Executive Committee of the Reproductive Health Supplies Coalition. She is a leader, an advocate, and authority in population, human rights, gender equality, and sexual and reproductive health, rights and health. Beth Fredrick is going to do our opening remarks. So over to you, Beth.
Thanks, Reina. It's a pleasure to be with everyone, and I just looked at the participant list, and I'm somebody who likes to make new friends, and there are so many new people on this call. I want to welcome you to the wonderful world of advocacy and effective advocacy at that. So many of you know, as Reina said, I'm the Executive Committee Chair of the Reproductive Health Supplies Coalition, but I'm only that because I worked for at least most of my career as an advocate, but in the last 15 years, I was privileged to be a part of the Advanced Family Planning Advocacy Initiative. And I want to tell you that at the beginning of Advanced Family Planning, we weren't sure how we were going to affect public policy and practice. And we tried to do it at the very highest level of government and with lots of other stakeholders to try and see whether or not we could get big wins for our issues around contraceptive access and availability. Next slide. But everybody knows that the greatest journeys that we take on begin with one step. And in this case, I'm sharing this slide on advocacy for task sharing, policy, and funding, because you need to get a sense, I wanted you to get a sense of how many entry points there are for advocacy. When we were working on task sharing, and that was just one element of the Advanced Family Planning Initiative, we realized very quickly that there were a lot more openings. There were many more openings for advocacy at different points along the journey for seeing especially a contraceptive development move through all the different places where it could be accessed. So we worked with pharmacies, for example, and pharmacists were not necessarily our first target for advocacy, but they were an important one. We looked at the essential medicines list. We looked at funders beyond the national government. We looked at subnational governments and at private providers and private insurance. We looked at guidelines, which were very important along the way to seeing a new advance move forward. And we also looked at different ways in which we could monitor how drugs and other family planning innovations were included in the management information service. The management information statistics in different countries. So this is just to give you an overview of the different kinds of points that you can access when you're advocating for new and underutilized reproductive health technologies. I'm not going to go into anything else. I just wanted to welcome everyone and make sure that you understood that advocacy is at the heart of the Reproductive Health Supplies Coalition, and we welcome collaboration with you along the way. Thank you so much.
Next slide, please, Marty. And thank you, Beth. It's so great to have your expertise on today's call. We are really pleased to introduce our colleague from the Access Collaborative, Miranda Buba-Atare, as our first speaker. Miranda is a pharmacist and public health supply chain specialist with JSI. She is the country coordinator for the Injectables Access Collaborative, where she works closely with the Nigeria Federal Ministry of Health and other stakeholders to scale up access to DMPA-SC and self-injection in Nigeria. In that capacity, she also serves as one of the AC's self-injection ambassadors. Over to you, Miranda, and next slide, please.
Thank you, Bonnie. Next slide, please. I'm happy to be here. I will provide a quick background into the Nigeria context. So the country aims to achieve a modern contraceptive prevalence rate of 27% by 2030. However, currently our MCPR stands at 20%, and the unmet need remains quite high. However, despite the challenges that we face, the country still remains committed to ensuring that there is a rich policy enabling environment to expand high impact family planning practices, and also to ensure that there is an expansion and coordination of new contraceptive technologies, and that we are able to promote policy-driven self-care for FP access and uptake, ensuring that we're able to expand access and choice for ST. Next slide, please. So over the years, Nigeria has achieved quite significant milestones over the years in terms of integrating DMPA-SC into the National Family Planning System and expanding access to self-care interventions across sexual and reproductive health. In 2015 and 2016, the DMPA-SC pilots were conducted in the private and the public sector. By 2018, the National DMPA-SC plan had been launched, and the task-shifting, task-sharing policy had been revised, allowing for an expanded human resource for health to be able to provide health services, including DMPA-SC. In 2019, we saw the development of the National Self-Injection Guidelines, and in 2020, we had the self-care guidelines developed. So the self-injection and the DMPA-SC guidelines are specific to family planning. However, the self-care guidelines include other self-care interventions, such as ensuring that women have access to HPV self-sampling services, HIV self-testing kits, they're able to manage their pregnancies with support from health workers. And we have a whole basket of other interventions that are available through the National Self-Care Guidelines. In 2022, the task-shifting, task-sharing policy was further expanded to include the self-care and self-injection functions, because self-care expands across several program areas and public health priority areas. There was a need to have a coordination mechanism. And in 2023, the National Self-Care Coordination Committee was established, and domestication efforts began at the subnational level to ensure that the policies translated to action across the different levels of the health system. In 2024, we were able to achieve another milestone, which was expanding the DMPA-SC plan to include expansion and sustainability functions. Next slide, please. So the policy advocacy and coordination efforts have yielded a lot of positive results. The self-injection indicators have been integrated into the HMIS. We have seen the TSTS policy support expanded roles across both the public and private sector. And for DMPA-SC and self-injection specifically, we have seen steady progress, with the percentage of DMPA-SC visits for self-injection increasing significantly since 2020. Next slide. So why did we see the need for a policy review? We had progressed from the product introduction and scale-up phase to reach the expansion and sustainability phase. And so we needed to see strategies to support scale-up to reach communities, underserved populations, and also expand further to the private sector services. We also had a lot of those previous plans and guidelines based on evidence and learnings from other countries. And to promote ownership and ensure effectiveness, we saw the need to leverage on in-country evidence that we had gathered across the years. There was also a need to leverage on the comparative advantages that are provided by the private sector and utilize a total market approach for scale-up. We also saw the need to review the service delivery considerations. So the Nigeria policy did not allow women to take home any doses when they were trained on self-injection at the first visit. So even if she was trained and she was found to be competent to self-inject at the first visit, she had to return to the facility after 3 months, where she was confirmed that yes, you can self-inject, and then she was given some take-home doses, and usually these take-home doses range from 1 to 2 units only, and we had sufficient evidence to show that this affected continuation rates. We also received a lot of feedback, and we saw a lot of findings from implementation that the way the training was implemented for self-injection was very cumbersome. It strained health workers, and it also meant that clients spent quite a lot of time at the facility. And so, especially in the private sector, a lot of the trainers, a lot of the providers were hesitant to even train women to self-inject. They felt the process was really too long. And then the previous plans and guidelines had very limited considerations for people with disabilities, for the youth, and residents in humanitarian settings. And so to ensure that everyone that needed access or wanted to opt for self-injection had the opportunity to do so, we felt it was important to include equity considerations into the new guidelines. Next slide, please. So what we did was to employ a very coordinated approach to stakeholder engagement. We looked at the gaps, we looked at the challenges and the advocacy needs, and we started to prioritize the stakeholders and identify them. We started to look at who could provide evidence and learnings to support some of these, who could help us to address some of these challenges, who were those that had some influence, some expertise, and also who were those stakeholders whose concerns needed to be addressed so that we would have full scale up. We had a lot of challenges from some regulatory organizations that were hesitant about some cadres of the private sector being able to provide these services. So it was important to bring them to the table and to collaboratively work towards the review of the policy. We also planned the engagements well in advance. The Federal Ministry of Health and Social Welfare developed a roadmap and an engagement plan to ensure that we had specific stakeholders invited. We had enough time for the review and robust engagements. We also prioritized collaboration, engagement, speaking to the different participants, both at the workshops, through virtual meetings, and also using health facility visits to talk to some of the providers. And we made sure that we continuously communicated and provided feedback through the process. Next slide. So like I had mentioned, this approach prioritized coordination and collaboration. We had close to 100 participants, stakeholders, contribute their perspective to the review. And these stakeholders were from the Federal Ministry of Health. The Family Health Department led the process, but we had the Department for Planning, Research and Statistics. We had the Department for Food and Drug Services, and also those responsible for managing data systems across both the service and logistics data systems nationally were also included. The National Primary Health Care Development Agency, regulatory bodies, the state ministries of health, and state primary health care development agencies were also adequately represented. We had a lot of implementing partners across the different sectors, across different capacities, and also areas of expertise. And we had strong engagement from donors and funding organizations as well. They were strongly represented at every step of the way. Next slide. So a key driving force behind the review was the fact that we used evidence-based recommendations, especially from the country context, and a lot of advocacy. So at the initial stage, we had looked at where the gaps were, what were people's concerns around scale up, what were the bottlenecks, and we were able to gather expertise, learnings from different implementing partners, research that was done both at the country level and the global level. And we brought these to our engagement meetings with the stakeholders. We were able to support recommendations on service delivery. And so we had in-country learnings that showed that if a woman got DMPA-SC, competent self-injection client, got DMPA-SC units, 3 take-home doses from the first units, it would improve continuation rates. And also, in terms of training, we saw that if we emphasized the MAPS critical steps, 4 critical steps, it was effective enough to train a self-injection client, and also would shorten the time, the training time, and the burden, the strain on the health workers. We also had a lot of evidence to support empathy-based counseling approaches that had been tested both in Nigeria and other countries. And we had representation from the states, from the humanitarian sector, where we were able to get lessons. The humanitarian sector stakeholders showed us their proven strategies for ensuring that women in IDPs or women that were in conflict areas actually had access to self-injection services, and also stakeholders that supported us with their policy insights for the private sector to support the total market approach. Next slide. I would really like to underscore the fact that success stories really impacted our engagements and our stakeholder meetings, especially at the action planning meeting, where we were looking at the challenges and the bottlenecks to scale up. And we had state level representatives give us account of their interventions targeting communities for the blind, and where blind women were able to successfully self-inject and take up self-injection. And this really created a lot of aha moments for a lot of the participants, and also even the providers and FP program managers. So the SI clients, the self-injection clients, also came to these meetings, and they provided their own perspective and underscored the need as well for them to continue to self-inject. One of the major challenges and causes of hesitancy to updating the service delivery protocol was concerns around product availability. So a lot of the stakeholders felt, how do you increase take-home doses when there are frequent stockouts. And so it was important to have the supply chain experts come and explain the supply chain considerations, the supply planning process, quantification, and also show that our forecasting accuracy for DMPA-SC had been above 90%. We had policies to support increased contribution to the basket fund, and states had actually approved budget lines and contributed funding to procure FP commodities at the subnational level. And so stakeholders felt, okay, if this state and this state can do it and expand their MCPR in such a short time and expand access, then we can do that too. And that supported the acceptance. We also, like I mentioned, had the health leadership from the humanitarian settings come and tell us how they used soldiers and people from the military to be part of community outreach programs to reach women who would otherwise not be able to reach facilities. Next slide, please. So the whole policy review process took a very relatively short time, but this was because of the immense commitment from the Federal Ministry of Health and Social Welfare, and also from the numerous stakeholders that were involved. The first step was coming up with the justification and the advocacy goals, which was done collaboratively with the Federal Ministry of Health in the lead, and also a caucus of self-care partners that we have been working with for a very long time. We had the action planning meeting to share experiences, understand where the challenges were, which areas we needed to revise, what the evidence was, and to get buy-in and acceptance. And then between May and June, we had numerous engagement meetings. We had the workshops. We also had smaller virtual meetings to make sure that we compressed the introduction and scale-up plan with the self-injection guidelines and incorporated all the strategies and learnings into the expansion and sustainability strategy, which was submitted to the National Reproductive Health Technical Working Group meeting for broader review. And at the end of this very rigorous process, we were able to return it to the Federal Ministry of Health for final review and recommendation. And the recommendation for approval, the expansion and sustainability strategy, was approved in August and launched in November of 2024. Next slide. So we've learned a lot of lessons along the way. One was really to plan early, to collaboratively identify where the bottlenecks are, what are the challenges, what are the areas of resistance, and how can it be addressed? How can we use data and advocacy to inform these strategies? We leveraged a lot on ensuring that we had the data, especially country-specific data, local evidence, and best practices. I had mentioned that the success stories really helped to support the acceptance by the regulatory authorities and also from stakeholders. The supply chain experts as well were very helpful in helping us to explain the quantification and supply planning in such a way that stakeholders understood that we were planning adequately for the women, where the gaps were in terms of procurement, and what the country was doing at the national and subnational levels to ensure that we rely less on donor funding and are able to look inward bringing success stories from those states that had already started to key into the state-funded guidelines for procurement of FP commodities, including DMPA-SC. I had already mentioned the stakeholder engagement was very inclusive, both from the government level, implementing partners, donors and funding agencies, but also clients and providers across both the public and the private sector. And collaboration was also very important. This we are seeing the importance of now as we have launched the expansion strategy. Everyone is on the same page. And so implementing and supporting trainings becomes something that we're all on the same page on. Next slide. So we had completed the review of the expansion and sustainability strategy. It was approved and launched. And so we have started as a country to review the training materials so that we're able to equip the trainers, providers, both in the public and the private sector, to be able to administer DMPA-SC safely. We're also leveraging on our learnings from the review process and from the demand generation strategy to make sure that we are targeting advocacy efforts to include those women who are usually left behind, including the youth and those that are resident in humanitarian settings. Next week, we are about to conduct a family planning supply chain assessment that is going to highlight the gaps and challenges in the family planning supply chain and identify opportunities and actions to improve the family planning supply chain system so that going forward, we'll be able to have the products to support expansion and sustainability. And we are also working on policies, the private sector engagement strategy, and other guidelines to make sure that we're able to involve the private sector in expanding access to DMPA-SC. I think that is my final slide. Thank you.
Thank you, Miranda. And next slide, so we have the Q&A up in the background. As you noted, Miranda, this is a recent policy update, though it's reflective of years of groundwork and advocacy to expand access to self-injection and the broader DMPA-SC product. This is also an excellent description of the practice of policy monitoring and adaptive advocacy around policy that is already being implemented. And in this case, to ensure program implementation met women where they are, where they were, and that the services were better suited to their needs, as well as those of the healthcare providers. So this is a really helpful description in your last slide, wrapping up how you're looking ahead to the implementation of the revised policy is really helpful. And I think emphasizing some of the key steps taken along the way to bring stakeholders with you and secure their buy-in for, a topic that was not necessarily open for everybody. There's a lot of discussion around some of these elements, particularly the dispensing protocol. I do have a question for you, but we are at time for this portion of the webinar, unfortunately. So what I will do is put my question for you into the Q&A box, and then you can respond to that in the Q&A, what's it called? Tool. And there's a couple other questions in there as well. And so we'll have Miranda respond to everybody through the Q&A element of Zoom. And with that, I'll wrap up our live discussion here, Miranda. Thank you very much, and pass it over to Reina for the next presentation.
Thank you very much, Bonnie. Moving on, I am going to present the next section related to menstrual health. And I'm going to present the two speakers. We have Arundhati Muralidharan and Tanya Mahajan. They are both co-founders of the Menstrual Health for Impact, which is an ecosystem enabler leveraging menstrual health to add women's health and well-being. Dr. Arundhati is a public health professional with 2 decades of experience in health programs, research, and policy advocacy. She has worked on several She has worked on several pressing public health issues, including HIV/AIDS, sexual and reproductive health and rights, and universal health coverage in India, doing social determinants of health and water, sanitation, and hygiene. Tanya Mahajan is also a consultant to global health organizations like the PAD Project and PSI Europe, and sits on the India and ISO committees for menstrual product standardization. She has over 14 years of experience in leveraging market-based approaches for public health issues in low-income settings, and holds a bachelor's in economics and MBA in finance. And they are going to make a presentation on advancing menstrual health products standards and the impact that it has had, and particularly in India. So over to you, Tanya and Arundhati.
Thank you so much, Reina, and thank you all for giving us this opportunity to share some of our reflections as we've worked on advocacy related to menstrual health in India. If you could move to the next slide, please. So as Reina said, Tanya and I represent an organization called Menstrual Health Action for Impact, and our goal is to work with stakeholders at the larger ecosystem, which is government, donors, NGOs, private sector players, small and medium enterprises, to use and leverage the menstrual health lens to improve women's and girls' health and well-being. And across this journey that we've had, we've got several lessons that we've learned on what it takes to do advocacy, and what especially advocacy with the government. One of the very first lessons that we learned was to leverage the power of the collective, and how relevant and critical collective action can be. When we started out, we didn't start out as an organization, we actually started out as a network in 2017. And our main purpose of forming a network was to create a space for very rich collective advocacy, where we could bring together diverse actors that we were seeing in the space of menstrual health, and provide them with a platform to share ideas and to figure out how we could work together to then influence and inform the government, both at national and at subnational levels. Very quickly, we realized that it was important for us to then begin to build consensus around key advocacy asks, because organizations were doing their own thing. They have very critical insights. But in order for us to present key policy recommendations to government, we had to also then build consensus between ourselves and across the various sectors and types of stakeholders who were engaged. So this meant that, I come from we come from the NGO world in India. So it meant that we had to bring together civil society organizations, NGOs, but also importantly, the private sector, who are often kept separate from such discussions. So this included also the large private sector organizations working on menstrual health, like the large product manufacturers, but also small and medium enterprises who were entering this space in 2017, but whose voices were not really heard. We were looking at researchers, those engaged in monitoring and evaluation, and also government that was, more in charge of implementation, so really at the ground level. So how do we then bring these actors together? What we realized worked very well for us is that as a neutral group, we were able to provide a space that was safe, that was open to hearing the diversity of voices and open to that engagement. And over the years, we've been able to maintain that kind of space, neutral space, to allow for such discussions. If we go to the next slide, share 2 examples with you of how this we have done. This hasn't necessarily been an easy process for us, as anyone who's engaged in collective advocacy, including the RHSC, will share. But this has been important for us. Now, 2 things that we've done. One is standards for reusable menstrual products. As many of you know, while countries do have standards for single-use products like pads and tampons, reusable products, cloth pads, menstrual underwear, menstrual cups, etc., that's relatively new globally, and was also very new for us in India. But we felt that this was an important opportunity for us to push for standards, and we had a critical government opportunity to do so. We had a government agency that set standards, our national standards body, that was open to such an engagement. But this meant that we were also reaching out to the rich, but very diverse community of people engaged in the reusables, in manufacturing reusables. And this consisted of companies that were doing so in a more focused manner, with focused manner meaning that they were looking at selling their products. And this also meant that we were dealing with NGOs that were making cloth pads in small units at a village level, in a slum level, for free distribution, for emergency distribution. And for setting these standards, we had to bring these very diverse groups together. Yes, they were all manufacturing reusable cloth pads, but the way they were manufacturing it really differed. And also the intent of their manufacturing in terms of whether they were looking at sales or creating a sustainable business model versus free distribution, that was also different. As a consequence of this, we also had very diverse opinions on the needs for standards. But I think it took us more than a year, or I think almost 2 years of constant back and forth, negotiations, discussions that were oftentimes extremely challenging, got quite heated, to come to an understanding of why it was important to have standards and which type of organization or company that standards would be applicable to in terms of the manufacturing of the type of product. And at the end of this process, we were able to effectively work with our national standards body to establish reusable standards. Standards for reusable cloth pads and period underwear in 2021. And we started this process in 2018. So it took us about 3 years of engaging with diverse stakeholders, making sure that they were heard. I think that is one important thing. The other thing that we learned in this process is that while we moved ahead with standards, there were some of our friends and colleagues who were working on reusable cloth pads who were not happy that the standards actually went through, because they represented small organizations that were supporting local manufacturing of cloth pads, which were not able to meet these quality standards. We wanted to make sure that we're creating a space. So as standards are set in our country, they're also put out for public comment. And we encouraged our colleagues and our friends to actually raise their concerns with who these standards would be applicable for, what kinds of products would they be applicable for. As a result of which, even last year, standards have been made mandatory for all menstrual products, single-use and reusable menstrual products. We've seen that products that are made by self-help groups or in very small manufacturing units and that are not necessarily manufactured with the intent of sales or making profit, they are currently exempt from the standard. So the process of providing a safe space for others to raise their voices and raise their concerns has resulted in an exception to the current standards as well. And we've also been able to then maintain these relationships. We're able to maintain these conversations as we're moving forward to see that how can we then help these organizations improve the quality of their manufacturing, the quality of their products that they and the self-help groups are manufacturing. Another example for us is we had an opportunity with the Ministry of Health and Family Welfare in India to inform new national policy for menstrual health and hygiene in 2023. Again, from the time MHAI started in 2017 till now, we've seen exposure of people and organizations who are engaged in this space. And when we wanted to influence the national policy in 2023, we thought it was really important to bring together again the diversity of voices. So this included individual activists, included small NGOs, large NGOs, manufacturers, those engaged in waste management, those researchers, etc., who were not engaged in previous menstrual health policy processes. Again, it took us, I think, about 4 months of very of regular meetings with different types of stakeholders, oftentimes holding different meetings or separate meetings with these stakeholders to make sure that we were capturing the diversity of insights that existed within our large community of practice, and figuring out how to bring all this together in a feedback document that we were able to successfully submit to the Ministry of Health and Family Welfare in India. Not all those recommendations were taken into consideration, but again, the process of creating space, provide that platform for the diversity of voices was an important process for us. Next slide, please. A second big lesson that we learned very early on in the journey and that we hold on to very strongly now as we've set up our organization is that with some governments, as we've seen with our own government, policy advocacy sometimes is best done when we position ourselves as providing technical support, and we're able to provide technical support consistently in the long term. So the initial offer of providing technical support gets us a seat at the table, and the quality of that support and our commitment to that long-term engagement keeps us at that table. We have seen that some governments, while activism-led advocacy we think is very important and should be continued, we do see that some governments are not as open to this as others are. And we have to keep that in mind, because our ultimate goal is that we want certain policy change, and that will support the health and well-being of our communities. Given where we are in India right now, we felt that in place of activism, we to provide technical support to the government, and we're able to leverage our strengths and the strengths of our network and partners to be able to do that. And there are a couple of examples of how we've been able to do that. So Reina, if you could move to.
Okay, I think we may have lost Arundhati, so I'll just quickly chime in the examples that she was going to mention. I think both the standards development process and also providing technical guidance to the ministry engaged with solid waste management on menstrual waste management solutions. These have been very technical focused, capturing evidence from different stakeholders, and synthesizing that evidence and presenting that to the relevant government departments and ministries has been how we've sort of presented the case, and it has been taken up and has led to a long-term engagement for us with different stakeholders in the country. Arundhati, you're back. Do you want to add anything to this?
Yeah, I think just one thing, I just wanted to give an example of, again, on the menstrual waste management. Again, we've been able to also pick areas that government needed technical support. And going back to our first point is we were able to rally the community of practice who had piloted innovations or were testing new technologies for menstrual waste management, and draw upon those insights and to break that down. And why this was important is in India, as in some other countries in the world, when you look at something like menstrual products or menstrual waste management, we can have strong and important advocacy stance, which are environmental in nature, or which promote a particular kind of product because it has the least environmental impact. But this, we noticed, was not sitting well with the government at all, because they were looking at, tell us what to do. Don't tell us what's not working or how hazardous or how dangerous a particular solution is, whether that's a product like a single-use sanitary pad or a waste management solution like incinerators. And again, here's where we were getting stuck in our advocacy or our activism efforts. So we needed to switch gears. We needed to say, okay, let's look at those hardcore solutions. What's the positives of those solutions? How would you implement those solutions? What's the processes? Who all need to be engaged? What's the technology behind it? and be able to present that to government in very clear, doable, process-oriented ways. And that we've realized has worked in at least kind of having those recommendations heard. So yes, so that's been quite critical for us to flip the way in which we do our policy advocacy and frame it as technical assistance. Again, this may not be necessary for all kinds of governments, but where we are sitting right now, that's the best way that we're able to get a seat and retain that seat at the table.
Next slide, please. Thanks, Arundhati. And just to take up the point of the technical engagement that Arundhati was just speaking about cannot be done without evidence and without data, but also using data and using evidence that is acceptable to the stakeholders that we are speaking to. Data is only as good as the story that it tells. And for us, I think good advocacy is good storytelling backed by acceptable and good evidence. So for us, one of the key learnings has been using the right kind of data sources which are acceptable or approved by the government stakeholders that we are speaking with. I think in many, across many countries, LMIC's global data sets are favored, but in India particularly, we've learned that using the DHS data from in country, the National Family Health Survey and other data sets which are generated within the country are much better favored by government stakeholders. So we have tended to use those data sources better to make the case for whatever advocacy asks we have put forward. And also then using those data points to really make flipping the narrative from what's missing to what's the opportunity. Because as Arundhati presented, the government is almost fatigued listening to these are the problems. They're looking for solutions. So what's the opportunity? So taking the simple case of, data access to products, data on access to products, the National Family Health Survey data does measure access to menstrual products for 15 to 24-year-olds in India. And that can easily be used to say whether access has increased or not increased. But it's not a very linear point that we make. When we sort of look at the nuance of that data set, we also see that a lot of people are using cloth, which presents the opportunity for reusable cloth pads, which presents the opportunity for choice, including informed choice in product access. And so we've used the same data that's been used to say, okay, access has improved or not improved, to say what's the opportunity, which is to make the case for informed choice. And the same goes for, I think, data sets like LEAP, which present a great opportunity to make that case in other countries as well. And also packaging data in a way that we present progress on indicators which are important for the government. Government stakeholders are unfortunately not going to create new focus areas for us. And menstrual health particularly is a very siloed area. It doesn't find ownership with a lot of people. So finding key progress indicators within existing programs has also been an important pathway for us, whether it's adolescent health indicators, anemia indicators, indicators related to education, labor force participation. These are all closely linked with menstrual health access. And we've used some of these data sets to find space within existing government programs and make the case with different ministries and departments within the government. The last point on data I would like to say is that disaggregating data. I think it's very important to look within and take a deep dive into what else can be said, looking at how data can be sliced by various socioeconomic and demographic indicators, by regions, by cultural indicators, by caste, whatever the relevant sort of buckets might be for your region. It can really present an opportunity to make a nuanced case for advocacy. Next slide, please. The last key lesson that we've had is how do we take our lessons from local advocacy to global platforms? And so we've done this to quite an extent with the standards advocacy. We've engaged very actively with the Bureau of Indian Standards since 2017 on creation of standards for menstrual products within India, and have taken those lessons then to ask for engagement by the Indian Bureau of Standards within the ISO platform. So the ISO has also started making standards for menstrual products. And with this advocacy, BIS has started to participate, and we are able to bring in more and more diverse voices through our collective and through our network into the ISO platform as well. But it's not just one way. I mean, this also gives us the opportunity to give voice to our country level leaders to present their voices at a global platform. And when they do that, they are also able to take back lessons from the global platform and are more open to adopting them within country. So using global best practices to optimize local advocacy. And usually if a government level stakeholder is part of those global advocacy convenings, they are much more open to adopting them in country than if someone else is just coming and presenting the case, because usually then they say, okay, this works elsewhere, but it doesn't work in our country. So these are all very important lessons for us on how to take the learnings from what's working in country and inform global work. Another area where we are trying to do this now is applying the lens to decentralized product access models. There's been a lot of investment over the years in decentralized product access models within India. And it is only now that the same is happening in other countries in sub-Saharan Africa and the Pacific region. But there's also lessons on what doesn't work. How can you optimize some of these pieces? And we are looking at how we can take the lessons from the local advocacy that we've done within the country to really inform other work in other LMIC settings. Next slide, please. Yeah, this is just to take away from one of the last ISO meetings, which we were a part of. And it's really been informed greatly by the participation of so many low and middle income countries, which is increasing with every passing day. Next slide, please. I'll pass it back to Arundhati for the key takeaways. But before I do, just wanted to say that I think looking at advocacy, it's just a way to tell the story. I think it's important to look at who you're telling the story to and how solid you can make it with strong evidence. Giving it back to you, Arundhati.
Great, thank you. I know we're close to time, but you see the points in front of you. I just want to highlight three. One is, I think there's no silver bullet for advocacy. We're all trying and testing different ways of doing stuff. We also realize that our political leaders or our decision makers do change every few years, and we may require different types of advocacy strategies to work with new leaders who come our way, because we're in it in the long game. I think the last point for us is, while daunting, while intimidating, while challenging, nurturing collective efforts is really key. And they're great to see platforms such as RHSC that do this. It's a tough job, but it is a fantastic, compelling, sustainable way to support to support advocacy efforts. So with that, thank you all.
Thank you so much, Arundhati and Tanya, for this amazing presentation and for sharing these important insights on a subject like menstrual health supplies, which are a very particular case among the reproductive health supplies categories. And it's also not usual for governments to look at it the same way, like family planning or maternal health. Thank you so much for all of this. I think we have time for one question. And we have a question for both of you, and it is, does your team focus on advocacy standalone, or do you also have grassroots presence and implement projects yourselves?
Yeah, so while we do not have our own implementation, we do not have grassroots presence. This has been intentional because we want to use the work that we do across different stakeholders to inform people who are implementing. There are organizations, very good organizations, great organizations, whose strength lies in grassroots work. And our focus is to use evidence and use the advocacy we are doing to inform their work. Arundhati, anything to add?
No, nothing more to add.
Thank you so much. We can move on for the next section then. Next slide, please. Okay, now I'm going to present the next speakers on the hormonal IUD. Dr. Marcin Solomon and Audrey Fratus, which are from the Hormonal IUD Access Group, which is a global consortium of family planning method introduction leadership dedicated to expanding access to the hormonal IUD. Dr. Madsen is an accomplished consultant gynecologist and obstetrician with over 30 years of experience in reproductive health, family planning, and maternal, newborn, and child health service delivery, including serving as the FHI 360 Kenya country representative and technical director. Dr. Solomon currently advises select FHI 360 family planning and reproductive health projects. And we also have Audrey Fratus, which is a senior technical officer at FHI 360, where she specializes in global contraceptive access with a focus on hormonal IUD. Her work includes support of implementation science research on hormonal IUD adoption and leadership of knowledge exchange and community building functions for FHI's 360 hormonal IUD coordination portfolio. They are going to present global policy changes that led to in-country access to hormonal IUD and how these global level changes were received and weighted by the Kenyan leadership as they made the decision to pursue hormonal IUD introduction. Over to you.
Thank you so much, Reina. We're so happy to be here to talk a little bit about creating a global level enabling environment for national level hormonal IUD procurement and introduction. So we're sort of wrapping up this session today by zooming way out to the global level. We're very proud to co-lead the Hormonal IUD Access Group alongside the Clinton Health Access Initiative. We can head to the next slide, please. So the hormonal IUD may be very familiar to some of you and may be brand new to others. For those of you who are less familiar with it, it has a 99.8% contraceptive efficacy rate for up to 8 years. It can be removed at any time during that period. And very relevant to our advocacy as an access group this year, it's also an effective treatment for heavy menstrual bleeding. So a little bit of background. The innovator hormonal IUD product received its first regulatory approval in 1990, and after that it was introduced gradually in high-income settings. Building on its momentum in those high-income contexts, in 2003, the ICA Foundation, which is a partnership between Population Council and Bayer, began to donate unbranded hormonal IUD product to geographies where the hormonal IUD was not yet available, which is low and middle income countries at that point. So in both those programs and in high income settings, we start as a community to see data suggesting high user satisfaction, high continuation, and what appears to be a positive impact on demand for other long-acting contraceptive methods, which is always what you want to see when you introduce a new option. So things are looking pretty good, but in the early 2000s, substantial progress towards global access would stall. And the reason for that stall are somewhat complicated, but the primary reason was that at that stage, there was only one quality assured hormonal IUD product, and it was available at a fairly steep price point, which meant that it could not be accessible through programs like the UNFPA Supplies Partnership. And that was kind of where things stood. We can head to the next slide, please. So for more than 10 years, there was very little major forward momentum, but that does not mean that there was no interest. So ICA Foundation donated units. The programs, the research that used them were sparking conversation about the hormonal IUD all over the world. Unfortunately, due to persistent price and procurement challenges and just the natural realities of the global SRH market, a lot of those conversations were happening behind closed doors. But in 2015, a second, more affordable hormonal IUD product was approved by the United States FDA. And the supplier of that product, which is a nonprofit organization, made a firm and ultimately public commitment to offering their hormonal IUD at a price point that was going to be workable for global procurement agencies and national governments. And then suddenly, after this big, long delay, global access was on the table. And all of the funders, the researchers, the service delivery organizations, the government leaders who had long hoped for low and middle income access were ready to bring the tough conversations about realizing the method's potential out into the open. So in 2015, the Hormonal IUD Working Group was formed. We would ultimately become the Hormonal IUD Access Group. And I don't mean to toot our own horn, but I do think as a group, we've set a standard for transparent problem solving around supply and demand side barriers to equitable access to family planning products. We can head to the next slide, please. So I wanted to give you all a little bit of a picture of what those barriers were, what we did about them, and what the impact was of that. So in 2015, very few essential decision makers at either a global or a national level had a clear picture of what the method could offer to individual users, local health systems, national family planning strategies, and experiences with the copper IUD and with high-cost luxury hormonal IUD colored conversation about the method. And so one of the big continuous steps we've taken as an access group has been relationship building with country governments to talk in general sense about their goals, their priorities when it comes to new product introduction, the challenges they want to solve, the ideas they had for new approaches, the resources and knowledge gaps they identified. And out of those conversations, we responded with context-appropriate resources, events, tools, and from this body of resources, we've found that organic interest from national governments has arisen because we were responsive to their focus and their priorities. And so what we're now seeing is rather than just the countries that had pilot studies for the hormonal IUD, had limited pilot projects for it, we're seeing interest come from countries that have no prior experience, but are hearing about the method in ways that work for them. Speaking of, the hormonal IUD has been extensively studied in high-income settings, but formal documentation of user interest and experience in the rest of the world was pretty low. And I can tell you that doubts persisted even among advocates for the hormonal IUD that there was a robust potential user base for the method in the country, outside of the countries that the method was already accessible in. And so in 2015, working group members committed to the collaborative development of a global learning agenda. That agenda was intended to produce the data that country governments had already identified as needing before considering method introduction. And so from about 2015 to 2020, little wiggle room on both ends, pilot studies started to tell a very clear story that not only do users like the hormonal IUD, but the method fills an essential gap in the method mix, and that users don't consider it to be interchangeable with other long-acting methods. In other words, it indicated that the method was going to play nice with a comprehensive method mix, that it wasn't going to compete unduly. And that data proved really compelling to national decision makers who began exploring the possibility of introduction and scale up. You'll hear a lot more about how those country decision makers were weighing that evidence when you hear from Dr. Solomon in just a minute. And then as the other speakers today have already mentioned, when you do advocacy, it's essentially never over. You never reach a point where you've done your advocacy, you've achieved your goals, and that's it. So I wanted to give you a picture of what's next for us. So this year, one of our key priorities is that implementing partners around the world have identified a need for consistent method awareness materials. So this year, we're working on a collaborative process with those implementing partners and country governments to produce method awareness materials that can be applied in a number of different contexts. As part of that, we're also engaging in an increased focus on the hormonal IUD's indication for heavy menstrual bleeding. One of the other active pieces of work for us is amplifying and disseminating the results of real-world introduction research, including through projects like SHINE and Lydia, which track the experiences of hormonal IUD users who got the hormonal IUD through routine service delivery. That we have this body of pilot evidence, but now it's available in real-world contexts. We need to know what user experiences are there. And then the last piece that we're actually working on this week is advocating for a distinct response option for the hormonal IUD in DHS surveys. So we're in the process of drafting a recommendation to DHS that under limited questions, the copper IUD and the hormonal IUD be split out from each other. Next slide, please. So I, as a matter of personal opinion only, can say that I think the supply side challenges for hormonal IUD introduction played a bigger role in limiting its ability to reach much of the world. We've already talked a little bit about pricing, that due to the small global market, the fact that for a long time there was only one quality assured supplier, the per unit cost was going to be unrealistically high for essentially all public sector procurement contexts. After that second quality assured hormonal IUD became available in 2015, price reduction did not just happen overnight. So for years, as an access group, we brought suppliers and other key decision makers to the table to have tough conversations about a potential volume guarantee, which was ultimately not integrated into the introduction strategy, the market size, all the things that drive pharmaceutical costing. We felt as a group that not only was there an argument for accessible pricing from a public health equity perspective, but that it was also just good business. And ultimately the suppliers agreed. So in 2021, the per unit cost for the method was closely aligned between the two quality assured suppliers. Behind the scenes of all of those conversations, and despite being available for more than 25 years, the hormonal IUD had not been added to a number of key decision-making resources, like the WHO Essential Medicines list. And when a product isn't added to a list like that, it has a trickle-down effect, that it would remain relatively unknown at both a global and a national level, and it likely could not be added to national EMLs. So while it's very difficult to definitively say what drove the decision, and I would not take credit for it as an access group, we do think it's likely that the rising tide of interest and conversation about hormonal IUD access pushed by the access group may have influenced the 2015 addition of the hormonal IUD to the WHO EML, which was a major barrier to come down. In response to that addition, we began to prepare for the possibility of new country interest. And then the final major institutional barrier to remain after these steps were taken was procurement. As many of you may be aware, many country governments acquire their family planning products through either the UNFPA Supplies Partnership or the USAID Global Health Supply Chain Project. And until the method was available in their catalogs, very few low and lower middle income countries would be able to place orders for it. Procurement agencies had been part of the access group since its very early years, tracking progress against other introduction barriers. And then in 2021, that last major global barrier came down. The procurers added both quality assured hormonal IUD products to their catalogs. Those decisions are often driven by changes in price, amplification of country interest, a product's potential clinical indications. We feel very strongly that focused collaboration with the procurers and a commitment to accessibility by suppliers and funders laid the foundation for that addition. And the first country governments began to place orders immediately following the addition. But again, work is not done on the supply side. Tough conversations about sustainable financing for the commodities and the health of the market need to continue to happen. So we'll continue to create spaces for donors and governments to collaborate about cost and access. One of our key focuses for 2025 is just making sure that country governments know what their options are for paying for the hormonal IUD, that we want to make sure that information about that reaches the folks who need it. And speaking of those decision makers, I'm going to hand it off to Dr. Marsden Solomon, who was part of the conversation in Kenya as the hormonal IUD began to be discussed. So we can head to the next slide, and I will hand it off to Dr. Solomon.
Yeah, thanks so much, Audrey, for that picture you have painted. Actually, it's very enlightening. So mine is just to indicate basically what were the events that really started in early 2005. And there was this global advocacy event that was there to influence the country level decisions in Kenya. So in 2005, as Audrey had mentioned, ICA Foundation began a small quantity donations, which actually helped to spur interest locally, that is in Kenya. And in 2010 to 2013, the innovator product launched in Kenya was there, and MSI was the main distributor. MSI means Marie Stopes International was the main distributor. Now, in 2013 to 2015, there was a pilot study that showed 16% of users were choosing hormonal IUD from a comprehensive method mix. That really was a telling set of evidence that really indicated how useful and attractive hormonal IUD was at that time. In 2016 and 2019, through the project of MCSP, JPIGO being the prime, it introduced hormonal IUD in 2 counties in Kenya, namely Kisumu and Kakamega, with the Minister of Health leadership and a learning component accompanying that. That really generated a lot of evidence to support that was used in advocacy to rally support for this particular method. Next, please. Next, please. Yeah, so the pilot data that was shown from within Kenya showing high acceptability and continuation rates, and also impact on the uptake of other family planning methods, which are aligned with the Kenya Ministry of Health family planning objectives and which triggered key policy updates. Now, betting on global level solutions to supply barriers at that time, the Kenya Ministry of Health established an enabling environment for future introduction. So with this kind of evidence, it went ahead to add a hormonal IUD information to the National Family Planning Guidelines for service providers in that year, 2018. It also ended up revising the Kenyan Essential Medicine List to reflect WHO inclusion of hormonal IUD. That was in 2019. Next, please. Now, when barriers did begin to come down, which were principally on the side of costing or the pricing, Kenya decision makers were ready to plan for method introduction and make essential structural changes. There was a cross-disciplinary plan development group that was established and which was led by the Ministry of Health and the Clinton Health Access Initiative. They made several considerations. One is to make available government and implementing partner resources. The other one was aligning the plan with the concurrent DMPA subcutaneous introduction that was also factored in. And there was also considering high impact geographies which had supportive environments and therefore making them ripe or conducive for implementation. And lastly, the KHIS, Kenya Health Information System, and registry updates and retraining were also included. Next slide, please. So what were the key progress indicators? 40 out of 47 counties so far are offering hormonal IUD. 400 plus facilities have already been trained to provide hormonal IUD. Out of the targeted quarterly insertion achieved, the achievement rate so far has been posted at 66%. What are the remaining opportunities for advocacy? One is to further train more providers in these facilities, because that is where the inadequacy is. There are many facilities have just about only one service provider trained in hormonal IUD, so there's need for more. And then there is the whole aspect of evidence and experience-based method awareness materials to be generated and used for the purpose of creating demand. May I turn this over to Audrey for the last slide to wrap it up? Over to you, Audrey.
Thank you so much, Dr. Solomon. So hormonal IUD introduction is still in its very earliest stages at a global level. And so it feels a little premature to have any major lessons learned, but also we've been doing this work on and off for about 30 years. So I wanted to share a couple of things that have stood out to us. The first is that a 30-year evidence to action gap is extreme, but it's not totally unheard of in the sexual and reproductive health field. And the processes for product introduction move very slowly. So I would say that the success for this method hinged on having champions, including many of my colleagues here at FHI, who were willing to wait it out and continue to build the evidence and resource base for the hormonal IUD to ensure that they were ready to move when an opportunity presented itself. Not every bet pays off, but I think a lot of advocacy, particularly in SRH development and introduction, hinges on people being willing to place big bets on important work. On that same note, a lot of global health change is a matter of perfecting your timing and figuring out which steps have to come first. In hormonal IUD access, building country interest, securing funding, bringing down some of those major obstacles was an exercise in pushing at the right moments. And within that idea is the fact that our key advocacy points, our intended policy changes, didn't happen in isolation. So for example, as our policy changes were ramping up, it was alongside major movement for implants and DMPA-SC, and a lot of folks were talking about new method fatigue. And it made it really clear to us that hormonal IUD advocacy would have to be about pull from decision makers rather than push from advocates. I think that can be a tough pill to swallow because as advocates, we often want to just get in the room and make sure people know what needs to happen. But the reality was we had to wait for countries to come to us. On that same note, I would say very few activities contributed more to country demand for hormonal IUD than the development and implementation of the global learning agenda. Hormonal IUD research allowed access partners to have clear, consistent messages about the method, and we see data and decision-making going hand in hand at every level, local, national, global. Even to this day, we continue to see national governments put learning and knowledge generation first when they make decisions about hormonal IUD introduction. And then finally, one of the very difficult things about global SRH advocacy is that a lot of decisions will happen behind closed doors, that regulators and commercial suppliers and international agencies are often limited in what they can share. And I think that makes community building and a commitment to transparency outside of those contexts even more significant. As we were putting this presentation together, I noted that so much of what we do as a group is really just getting people in a room together. And I'm always amazed at how far that can get you. So almost 20 countries are now introducing the method. Hundreds of thousands of units have been shipped, but we've got a really long way to go before every contraceptive user has the chance to decide for themselves if this is a method that's right for them. I think these lessons will continue to guide us as we push for change as a group. So thank you very much. I'm going to put our information into the chat if you'd like to learn more.
Thank you so much, Audrey. Thank you so much, both of you, for this interesting presentation. Dr. Madsen, hormonal IUD adoption and scale-up has been a longer time horizon, and I'm sure this information is very valuable to accelerate the timeline and process for other similar products. So we had a couple of questions in the Q&A box, but due to lack of time, we're gonna reply to them via email. So I'm gonna hand it over to Bonnie for the general Q&A as we have little time to continue.
Yes, we've got about 6 minutes left to wrap it up and have a couple questions for our presenters today. So thanks everyone again for your fantastic presentations. I've seen quite a number of comments in the chat about the wonderful quality of the presentations and information shared. As Reina mentioned, there are a few questions that have been submitted through the Q&A function, and most of those have had a response sent through. And so I, as one of the moderators, would like to use my privilege to ask a question to Tanya and Dr. Arundhati. You know, in your presentation, you noted the importance of technical expertise and the utilization of evidence. And actually, I think all of our presenters have commented on that, particularly as you're advocating with governments. And I want to ask, because many of our callers or participants as advocates have spent a not insignificant amount of time creating advocacy resources to use in their efforts. From your experience, what types of packaging of data or visualizing of data have really made things click with your decision makers? Like, have there been, particular types of resources that you found really helped move the needle in terms of getting them to take action, whether that's for a policy authorization or, most relevant for today's conversation, to really move something towards implementation, whether that might be committing financing, et cetera. But I'm curious if you've seen a particular format of resources or packaging of the evidence that has really helped move things forward from the menstrual health product side. Over to you for a response.
Thank you. Thanks, Bonnie, for that question. Excellent question. I think that's a question we continue to answer for ourselves as we work in this space. I think the formats can be various, right? You can have technical briefs, you can have advocacy briefs. Of course, the more visual they are and the less wordy, the more pointed they are in terms of the key messages, that's better. But for me, I think the most impact is when we repeatedly use those key messages or those data points or those visuals to reach the key stakeholders at important platforms. So whether it is in taking the example of standards, whether it is in our regular meetings with BIS or at important webinars, but presenting those same data points, those same key messages to those stakeholders, and them also coming from other important stakeholders. For example, the Ministry of Health also pinpointing to that data point. That has more of a recall impact for those briefs or visuals or whatever output we may have created. Arundhati, would you have anything to add?
Yeah, just to agree that it's not any single format that we've seen worked, but what does work is something that's very clear, very simple, and not to overwhelm with data. And the only other point that I would add is what's worked well across the board for us is a focus on solutions rather than on an overemphasis on outlining the problem. Governments do know what the problem is. They want to know what to do. And the more clearly and succinctly we're able to present that, the more the likelihood. And actually related to that, we found that when we present like a bouquet of options or bouquet of solutions, that also sits well with them, because then they don't feel like they're trapped to doing only this, that this is the only way forward. So if we said, well, NGOs have tried this, someone else has tried this, and here's another set, and here's the results that they show. And based on contexts, governments nationally and subnationally can try this. That's also something that's worked. But all of this has to be done very clearly, very simply as possible.
Yeah, absolutely. And I think those are two really great points about, focusing on the solutions as opposed to extensive background. And then the last point you made about, what was your last point? I'm zoned out a bit.
Of solutions.
Bouquet of solutions. Thank you. Well, I think we've got one last minute left, so I think I'll go ahead and wrap it up. Reina, was there any last point you'd like to make before we officially close down the webinar?
Oh, thank you, Bonnie. Well, there are so many important insights on this session. The role of advocacy within a wide ecosystem of stakeholders came up during the three of the sessions. Reaching goals is a collaborative effort. There is the importance of evidence-based recommendations and lessons learned. They all have these similarities. And also, I would only like to highlight finally the building relationship with governments and speaking directly to their needs during introduction. It was such an important part that I like to highlight from the three of the presentations. And thank you so much for all of the speakers. And I think we can wrap up now. We're exactly at the time that we should.
Exactly at time.
Yeah.
All right. Thank you, everyone. As Reina said, that is the end of our time together. We are going to be sharing a link to a recording of the webinar that should happen within the next week. Thank you to our presenters and to you all for joining us. We wish everyone a wonderful year ahead. Cheers.
Thank you.